Alright, next we're looking at the respiratory zone structures. And remember, if it's a respiratory zone structure, then it begins with the word respiratory or something related to alveoli or alveolar. So your first respiratory structure is what branches off of the last conducting zone structure, which is the respiratory bronchioles, which lead to the alveolar ducts, which lead to the alveolar sacs. And what makes up the alveolar sacs are millions of alveoli. And the alveoli are the sites of actual gas exchange. So we can actually look at now the respiratory zone structures. So branching off the terminal bronchiole, the first respiratory zone structure are the respiratory bronchioles. Here's the alveolar duct, which leads to the alveolar sac. And again, it's made up of many alveoli. And you also have elastic tissue surrounding those alveoli. Also, something important we're going to see is the respiratory membrane. This is essentially pulmonary capillaries meeting the air spaces, because there's alveolar pores that are connecting all of the adjacent alveoli. And so that gives plenty of routes in case of blockages for the air to get to those air spaces. The air is cleansed throughout its travel in the conducting zones, but also in the respiratory zones by alveolar macrophages. They're keeping those alveolar surfaces sterile. We actually swallow about 2 million dead macrophages an hour, and they're just keeping our respiratory system clean. Now, the respiratory membrane is where these air spaces you see here meet the pulmonary capillaries. Where the capillary endothelium meets the alveolar endothelium, that's the respiratory membrane. It's really important to know that the respiratory membrane is there for gas exchange. It needs to be thin because the type of gas exchange it allows is via simple diffusion, and diffusion is a passive process. So if this membrane was really thick, this diffusion would not be possible. Another definition for the respiratory membrane is just a blood-air barrier. Again, the parts is the alveolar and capillary walls and the kind of connective tissue glue or fused basement membrane that holds them together. Now, if you're looking at the alveoli, they're mostly type 1 alveolar cells, which is simple squamous epithelium, but there will be a couple of type 2 alveolar cells that are roughly cuboidal, and they secrete primarily surfactant, a detergent that keeps your air spaces open by reducing surface tension. Here in this image on the left, you can see the type 1 and type 2 alveolar cells. The type 1 alveolar cells, those are the tan cells, and you can see they're the most abundant. The type 2 alveolar cells that secrete surfactant, again, they're roughly cuboidal, but they're in green. And then on the right, you can see the respiratory membrane. And we can see where the air space meets the blood space. And this is where oxygen is loaded into the blood, and CO2 from your tissues is loaded into the air space. And again, this is where the alveolar epithelium, fused basement membrane, and capillary endothelium come together to create a thin membrane for diffusion. And again, that's for the gas exchange. The gases being exchanged were the respiratory gases. But outside of this respiratory membrane, we can also look at the gross anatomy of the lungs, because the lungs occupy all of the thoracic cavity, except for the mediastinum where the heart is. You have the area where the vascular and bronchial attachments are, that's the root. You have the area where the lungs touch where the ribs touch the lungs, that's the costal surface. And in the apex is the top tip or superior tip, and the base is the bottom broad part of the lung, and it's on top of the diaphragm. The hilum is also an area that's on the mediastinal surface like the root, and it's just a little broader. It includes not just the entry and exit for blood vessels or the entry for bronchi. It also includes the space where we see lymphatic vessels and nerves enter and exit. The lungs are also separated by fissures, and that's what separates them into lobes. The left lung has 2 lobes, the superior and inferior, and the right lung has 3, superior, middle, and inferior. Because the right lung has 3 lobes, it's separated by 2 fissures. The horizontal fissure separates the superior and middle lobe, and the right oblique fissure separates the middle and inferior lobe. whereas there's just a left oblique fissure to separate the superior and inferior lobes for the left lung. The left lung is also a little bit smaller than the right lung, mainly because of the position of the heart, and again the heart's a little bit more to the left than straight down our midline. There's even a kind of depression or a concavity for the heart to fit into called the cardiac notch on the medial surface of the left lung. We can see some of those structures here, like the different fissures, the apex of the lung, the base of the lung. We can see the base sits on the diaphragm, and we even get a good view at the pleurae. So again, the parietal and visceral pleurae, with the visceral being on the lung surface and the parietal being on the thoracic cavity wall, with a fluid in between those layers in a space called the pleural cavity. With no air and just fluid between those two layers of the pleural serous membrane, it essentially superglues the lungs to our rib cage. So when our rib cage expands, so do our lungs. When it depresses, so do our lungs. But also all that elastic tissue around the lungs really helps with lung recoil. Here's a look at the area where we have the vascular and the air tubes entering and exiting. Again, vascular is talking about blood. And this area again is the hilum, because we're not looking just at the area with the bronchi and the arteries and veins. This is also the area where nerves and lymphatics would enter and exit, making it the hilum. If we were to look past the lobes of the lungs, we can also separate the lungs into bronchopulmonary segments. And these segments are small, but they can actually be individually removed if a segment is diseased. The segmental bronchi, or tertiary bronchi, actually serve these segments. They each have their own artery, vein, and bronchus. These segments are separated by connective tissue. That part's called septa. There's always 10 segments on the right lung and 8 to 10 on the left. So here we're seeing the tertiary bronchi serving the different segments. So if you add up all of the segments on the right, so 3, 2, and 5, that's 10. And they're showing us 9 on the left, but it can be 8 to 10. Smaller even than the segments, but still visible to the naked eye, are lobules of the lungs. They're roughly hexagonal in shape, kind of similar in shape really to liver lobules, and they are served by bronchioles, not bronchi. The rest of the lungs is really the alveoli, or the air spaces. And on top of those air spaces, what really makes the lungs so elastic is the elastic connective tissue that serves as a network or stroma to really hold the lungs together. Again, that makes the lungs very elastic, very soft. There's also 2 perfusions, or 2 blood supplies, to the lung. You have pulmonary circulation, and then you also have bronchial circulation. Pulmonary circulation deals with the pulmonary arteries delivering blood that needs to be oxygenated. Those pulmonary arteries are delivering blood to the lungs, and that blood eventually gets to the pulmonary capillaries, and it meets the air spaces of the lungs so that we can get oxygen. And then the pulmonary veins carry that oxygenated blood from the respiratory zones back to the heart. Keep in mind, pulmonary circulation, it doesn't have to be high pressure. The lungs are right next to the heart. So this is a low pressure but high volume system. And that's great because there's different enzymes and other substances that react in this location. It's a great place for them to react together because all the blood has to travel via the pulmonary circulation. An example is ACE, or angiotensin converting enzyme, which actually is utilized to activate the blood pressure hormone that makes up the angiotensin-aldosterone mechanism. And then bronchial circulation is actually a part of systemic circulation. Bronchial arteries provide oxygenated blood to lung tissue, or essentially all the lung tissue except the alveoli. And then the bronchial veins that are draining the lung tissue, they join with or anastomose with pulmonary veins. And so the pulmonary veins carry most venous blood back to the heart. The lungs also have nerves, both parasympathetic and sympathetic fibers. When firing, parasympathetic fibers cause bronchoconstriction, and sympathetic fibers actually cause bronchodilation. That's a little bit opposite from what we've seen with the cardiovascular system. Usually sympathetic fibers with blood vessels cause constriction. and parasympathetic cause dilation. So it's swapped here. And a little bit more on the pleurae. Think back to chapter 1 in your textbook. Pleurae are a serous membrane, so they're double layered, they have a fluid in between them. Their main goal is to provide lubrication and also some surface tension and reduce friction as the lungs expand and recoil. The parietal layer, or in this case the parietal pleura, is on the membrane wall or thoracic wall. And the visceral pleura is on the external lung surface. Because of how closely the two pleural layers sit and the fact that there's fluid, not air, between them, it acts essentially as kind of a suction or super glue to the lungs. So when you breathe in, take a big breath. Note that your rib cage expands. As your rib cage expands, because your lungs are essentially super glued to your rib cage because of these pleural membranes, they also expand. Now take a breath out. As you let a breath out, your rib cage depresses or goes down, it decreases in volume, and that allows the lungs to recoil. What also really lets the lungs recoil is all that elastic tissue. The main thing allowing lungs to recoil to a smaller volume is elastic recoil of the lungs. And those pleurae that we talked about, they can get inflamed, usually from a virus like from pneumonia. That makes them rough, that results in friction, can be very painful when you breathe if they're inflamed. And sometimes the pleurae, when they are in this inflamed state, can actually produce a lot of fluid, and that'll push pressure back on the lungs, making it difficult to breathe. But if too much fluid also builds up in these areas, it can hinder breathing. It can also lead to something called pleural effusion, or fluid accumulation in the pleural cavity, which, if it expands too much, can interfere not only with lung activity, but your lungs staying inflated at all. So now we've reviewed kind of the basics of what the lungs look like, their anatomy. We've looked at the 4 processes of what we consider respiration. And we have a good idea not only of the anatomy, but basic physiology and really just the factors involved in the respiratory system now. So going forward, it is going to turn more to how we breathe. But for now, let's try some practice questions. True or false? The nasopharynx is a passageway for air only. That's true. How about this one? Which one of the following lists the respiratory passageways in descending order from nasal cavity to alveoli? Well, they all start with nasal cavity to alveoli, so that's not going to do it. But after the nasal cavity, you should move into the throat. And it looks like only A and B are showing up as possibilities then. So we can get rid of C, D, and E as options. All right, so A has nasal cavity, pharynx, trachea, larynx, and I already see a problem because my larynx should come before the trachea. The voice box comes before the windpipe. So B is going to be our answer. Nasal cavity, pharynx, larynx, trachea, primary bronchi, bronchioles, then alveoli. Of course, you could list more, but of the list, this one's in the right order. All right, true or false? The epiglottis is made up of elastic cartilage. Hopefully you very quickly said true. Remember, there's only 2 locations with elastic cartilage, the ear and the epiglottis. And the epiglottis is the only part of the larynx that is not hyaline. All right, which structure seals the nasopharynx when we swallow? I'll give you a hint. Makes up part of the soft palate. Ring any bells? Hopefully you said then the uvula, which is the back end of our soft palate, and that moves upward or superiorly to close off the nasopharynx so the food goes down and not up. But you can mess with this if you're coughing or talking while you eat. All right, and then the phase of pulmonary ventilation that involves gases moving into the lungs is called inspiration. True or false? That one's true. So breathing in is inspiration, and breathing out is expiration. And inspiration and expiration are the 2 phases of breathing, which is pulmonary ventilation. All right, blank is the structure that marks the beginning of the respiratory zone. Now, respiratory zone is separate from conducting zone, And anything that's a respiratory zone structure starts with respiratory or something related to alveoli or alveolar. So that really only narrows it down, well, quite a bit. It narrows it down to C or D. But it says beginning of the respiratory zone. So we want the structure that would be first. And that would be the respiratory bronchioles, because they branch off the last conducting zone structure, the terminal bronchioles. All right, oxygen and carbon dioxide cross the respiratory membrane into the pulmonary capillaries via a process called blank. It's passive. Hopefully you said diffusion. So it's passive diffusion through the respiratory membrane. And again, that respiratory membrane is where the air space and the blood space meet at the lungs. That's where pulmonary gas exchange happens and oxygen moves to the blood and CO2 moves to the airspace. Bonus points if you can think of the three parts of the respiratory membrane. I'll give you a second. One is capillary endothelium, fused basement membrane, and hopefully you said alveolar epithelium or airspace epithelium, because that's the third part. And that's it for part A of chapter 21. Make sure to look at the rest of the videos, because we're really going to start to get into the physiology and how everything works in the respiratory system now that we have this anatomy base.